Good afternoon. As Dr. Otterson discussed all the various cancer treatments, I'm going to focus on symptom management and how we as providers can support the patient. We know that smoking and nicotine addiction is chronic and relapsing. We often will say to our patients that you may quit 5-6 times before you'll really be able to quit for good. There are health benefits to smoking cessation even after your cancer diagnosis, regardless of what stage or prognosis that you're in. So why quit smoking? Research has shown that it can extend your life expectancy, reduce the risk of primary cancer returning or developing a secondary cancer. It can also reduce treatment-related side effects, as you see listed here for chemotherapy and surgery. We currently recommend that you do not use any combustible products, as you see listed, smokeless tobacco products, or e-cigarettes. We see a lot of advertisement right now on e-cigarettes, and the truth is there really isn't research outcomes that tell us what will really be the risk in the long-term use of e-cigarettes. It is recommended right now that the most effective program would combine combination of counseling and nicotine replacement therapy. They first recommend that you would use a combination of a long-term nicotine product with a short-acting nicotine product, such as a patch is long-term, a gum or lozenge or inhaler or nasal spray with nicotine in it, that is short-term. If that isn't effective, then they may move to the first drug of choice is varenicline, or you may know it as Chantix. If you will also combine that with a short-acting nicotine product. If that isn't helpful, they may also move to the next step of bupropion. Now, there is caution with both the Chantix, the Wellbutrin, that if you have brain metastasis, they recommend that you do not use it because of the risk of seizure activity could be higher. There are several causes of vomiting. In lieu of time, you can see the first 5 that are listed. Those are areas that we want to focus on and pay attention to. But then we also know that different types of chemotherapy are likely to cause nausea or vomiting than others. It can happen before or during or after your chemotherapy treatments. In regards to radiation, it's more likely to cause when you are treating your upper abdomen, such as the small intestine or your esophagus, or when treating the whole body, looking at the bone marrow or combined with chemotherapy. Different immunotherapy agents that you see listed here can also cause nausea or vomiting. The goal of managing nausea and vomiting is prevention and also reducing the severity of symptoms. I'm going to discuss the different types of nausea and vomiting so you can better understand why we use certain drugs at certain times. So during the acute phase, this begins a few minutes or several hours before you actually receive your treatment and can continue for about 24 hours. So our goal here is to prevent nausea and vomiting. So we will provide in your chemotherapy plan medications that we consider to be pre-medications before your treatment begins. And we might also continue those on an as-needed basis, or as we will call PRN. The common drugs that are used during this time period are listed there for your reference. Delayed nausea and vomiting begins about 24 hours after you received your chemotherapy treatment and can continue for 6 to 7 days after. Our goal here is to reduce the severity of your nausea and vomiting. We may give this on a schedule basis, such as using a drug such as Compazine every 6 hours or every 8 hours for the first 2 days. Or we may schedule dexamethasone, a steroid, for 3 to 5 days after the therapy has been completed. Again, the drugs for your reference are listed. Anticipatory nausea and vomiting happens before the next treatment is given, and nausea is more common. Usually this will involve some visual, some smells, or environmental factors that you associate with the past treatment that you received. Your provider might consider giving you a medication that can help reduce the anxiety. Commonly, benzodiazepine is used, and lorazepam is one that is commonly used. Breakthrough nausea and vomiting happens regardless of what medications you have tried. We basically use the same drugs that we have used during the delayed nausea and vomiting, and our goal here is to reduce the severity that you are experiencing. Refractory happens even if we've used the medications to stop or prevent. So we'll continue to use the drugs that I've talked about, but in addition, we can add some other drugs to help, such as dronabinol or Reglan or haloperidol or a scopolamine patch. If you experience dehydration due to excessive vomiting or unable to take good oral intake, we may use IV hydration. And then we can also use complementary therapies, and different programs have supportive services that will provide relaxation, hypnosis, imagery, music therapy, and acupuncture. Pain is defined as an unpleasant sensory or emotional experience associated with actual or potential tissue injury. Our goal in pain management is to optimize the pain control. This can sometimes be really difficult because there are a lot of patients that are fearful of taking pain medication, especially in today's world during this ongoing opiate addiction epidemic. We use a stepwise approach when managing pain, and the patient's report of the pain is our best measurement for treatment. When we're managing mild pain, we'll start with non-opiates. A common drug is used as acetaminophen, otherwise known as Tylenol. This can be used for general achiness. Non-steroidal anti-inflammatory drugs are otherwise known as NSAIDs. Ibuprofen is commonly used. This is helpful with myalgias or muscle aches or inflammation. Adjuvant medications could include steroids, which are helpful for bone pain, gabapentin, Neurontin, that are helpful for neuropathy. And if we need to use an opiate, we may start with a mild one that is considered to be tramadol. Moderate and severe pain will give us an indication that we should use for sure opiates and typically start with PRN or as needed drugs. So to begin with, if you're just needing it as the pain begins, we'll start with short-acting opiates. Common drugs are oxycodone and acetaminophen, hydrocodone, acetaminophen, or oxycodone, morphine, or hydrocodone. The medications that contain the Tylenol or acetaminophen may be removed from your pain regimen if we're fearful that it could mask a fever. If you continue to have persistent pain, then we will think to add a long-acting opiate to your short-acting opiate that we already mentioned. Long-acting opiates include extended-release formulations of morphine, oxycodone, fentanyl patches, or methadone. If a patient's pain is still not controlled with the pain medications, your provider may make other referrals. Common ones that we may use are pain and palliative clinic. It is helpful for long-term management and for more consistent management. As providers in the clinic, we're seeing you for a short period of time. So if we can have you work with a pain specialist, that is their only focus, and sometimes can have a better chance of controlling your pain over time. Anesthesia is helpful if we think that a nerve block or pain pump may be necessary, and radiation oncology may be used if we feel that we could use palliative radiation to a specific area that you're having a lot of pain. Common areas that you'll see radiation to are with bone metastasis. We also need to make sure that we're paying attention to adverse effects for pain medications. So you may see that bowel regimens are really focused on. We may have you do a stool softener as needed, or scheduled daily, or twice daily, or laxatives as needed, or scheduled daily. Antiemetics may also have to be adjusted, or medications may have to be changed if they are causing more nausea and vomiting. And in addition, complementary therapies, as we have mentioned before, may be helpful. Maintaining adequate energy and activity level is really important when we're trying, when we're having you go through your cancer treatments. Although cancer treatments commonly cause fatigue, providers will want to manage other symptoms that can increase your fatigue. We've already discussed pain. However, then you also have distress, which is usually could be a depression or anxiety. So stress management, medications, counseling, or complementary therapies are helpful. Anemia, which would be a low hemoglobin level, may also require you to have a blood transfusion. If you're having problems sleeping, your provider may provide a medication to help with the insomnia, such as melatonin. We also recommend a decreased caffeine intake and to help you get on a normal sleep-wake pattern. If you are having difficulty with physical function, we may make a referral for physical therapy or occupational therapy. And if a nutritional imbalance is contributing, then we may recommend you see a dietitian. Maintaining the highest level of activity is really important, even in a setting of having fatigue. So they recommend 3 to 5 hours of moderate activity weekly. If all these other things are ruled out or the additional therapies aren't working, they may prescribe methylphenidate, which is otherwise known as Ritalin. Immunotherapy agents were already discussed with Dr. Utterson, so I'm going to focus on the side effects. We've discussed the first 3 side effects earlier in regards to other symptoms, but one additional common side effect of immunotherapy is muscle or joint pain. So for this, we found that NSAIDs and opiates can be effective in managing that pain. Another reaction that we are aware of and try to prevent is your infusion-related reactions. These can occur at the time that you receive the infusion, and specific medications given as pre-medications in order to prevent this reaction. The symptoms that a patient may experience could include shortness of breath, cough, fever, chills, low blood pressure, low oxygen levels, all of those or any of those. At the time of the infusion, if these happen, the nurse will stop the infusion. They have medications that they can give to reverse the reaction, such as steroids, oxygen, Benadryl, epinephrine. They may then resume the infusion at a slower rate or stop the treatment altogether if the patient is not recovering. If the patient doesn't recover easily, the provider will discuss this with you and determine whether or not they need to continue the therapy in the future. This is kind of a busy slide, but the other side effects that can occur due to the inflammatory response of the immunotherapy. All the organs that are listed on the left are ones that can be affected by this inflammatory response. With the skin, this can involve side effects such as dry skin, rash, or itching. We can use moisturizers for dry skin, for itching, topical steroids for the rash, or oral histamine. For gastrointestinal, we may see diarrhea or colitis, so we can control that with Imodium to stop the diarrhea or hydration if the patient becomes dehydrated. The kidney, the lungs, the endocrine system, and the pancreas and liver, those will be seen more with labs. So the labs that we obtain from you before each of your treatments, we'll be looking at those. If we see that the levels are becoming abnormal or most commonly increased, we will hold your therapy for 1 to 2 weeks, and we'll wait to start the therapy once the organ starts to improve. Now, if you look over to the far left, if we've held that therapy for a couple weeks and the organ is not recovering, then we will have to begin high-dose steroids. Prednisone is the medication you'll see started. We'll continue this. It could continue anywhere from 4 weeks up to 8 weeks until we see that that organ is recovering. We also need to, as the organ begins to recover, we need to taper the steroids down. Now be aware, you're not going to be able to be on immunotherapy during this time. It can counteract the therapy. So the steroid therapies will have to be tapered off completely or to a very small dose before we can resume the immunotherapy. If the inflammatory response is not resolving, the provider will discuss this with you, and they'll have to determine whether or not that the immunotherapy will have to be stopped.